Welcome back to the Deep Dive. Today we're doing exactly what we promise, taking complex technical guidelines and making them clinically practical.
That's the plan.
And our focus today is sharp, aimed squarely at our colleagues in radiology and nuclear medicine. We're diving deep into the technical and clinical gold standard for hepatobiliary scintigraphy, HBS.
Yeah, getting into the real nitty-gritty.
We're talking precise techniques, those crucial quantitative measures, and maybe most importantly, the pitfalls you need to avoid for a really definitive report.
Absolutely. And we're grounding this whole discussion in the key consensus documents. We're pulling heavily from the Society of Nuclear Medicine, the SNM Practice Guideline 4.0 from 2010. That was a big collaborative effort, with ACR and EANM involved.
Right.
And also the British Nuclear Medicine Society, the BNMS Clinical Guideline from 2015. These aren't just suggestions. They really set the benchmark for quality and honestly for critical thinking in our field.
Okay, so let's level set quickly. HBS, it's fundamentally, we're using a radionuclide, right? Planar, SPECT, maybe SPECT TCT.
Right, exactly.
And we're watching bile get made and where it flows. So we're looking at two things: how well the liver cells are working hepatocellular function, and whether the plumbing, the biliary system, is open, patency.
That's it in a nutshell. And our mission today really is to extract those super practical details, the specific numbers like GBEF percentages, the precise timing for interventions, those subtle technical points like image scaling, things that can make or break your interpretation.
Yeah, the stuff that helps you avoid reporting an artifact as, actual disease.
Exactly. Boosting confidence in handling the tricky parts of HBS, #TAG-I, core clinical applications and context.
Okay, so when you mention HBS, I think most people's first thought is acute cholecystitis.
Right. That's definitely the classic indication, yeah. Though, interestingly, the BNMS guideline points out it's actually becoming less common for that specific indication in the UK.
Oh, really? Why is that?
Well, largely due to the increased use and accuracy of ultrasound for acute calculus cholecystitis. Makes sense.
Makes sense. But these guidelines show HBS is used for way more than just that. The range is pretty wide.
Oh, absolutely. It's incredibly versatile. Beyond acute cholecystitis, it's really critical for investigating functional problems.
Functional biliary pain, that's a big one, right? In adults and kids?
Huge. Especially for conditions like chronic calculus gallbladder disease, where there are no stones on ultrasound, but the patient has classic biliary pain. HBS, specifically the GBEF measurement, is key there. Same goes for kids with similar unexplained pain.
And then there's the whole world of post-surgical assessment.
Indispensable there. Checking if the biliary system is intact, finding bile leaks, that's a major complication after liver or stomach surgery. HBS is often the best way to pinpoint a leak.
And that critical role in newborns.
Yeah, neonatal hyperbilirubinemia, that's probably one of its most vital roles. Differentiating biliary atresia, which needs urgent surgery from neonatal hepatitis, which is managed medically. HBS is the main tool for that.
Right, because the outcomes are so different depending on the diagnosis.
Completely. We also use it after surgery, like checking the Kasai procedure done for biliary atresia or after liver transplants. Even things like afferent loop syndrome after certain types of gastric surgery.
The guidelines also mentioned assessing choledochal cysts.
Yep. It can help define the anatomy and drainage patterns. And looking forward, SPECT TCT is mentioned specifically for functionally assessing the liver before a partial hepatectomy.
How does that work?
You can use the tracer uptake, quantified with NEC-TTT, to map out the functional volume of the part of the liver that will remain. It's crucial for surgical planning, to make sure the patient won't go into liver failure post-op. Really powerful stuff.
Okay, but here's the big caveat that jumps out from the guidelines. HBS findings often aren't specific on their own.
This cannot be stressed enough. It's probably the single most important take-home message for interpretation. You absolutely cannot read an HBS scan in isolation.
So you see something like delayed transit.
Right. Does that mean partial obstruction? Or does it mean the liver function is so poor it can't excrete the tracer properly? The scan looks similar. You have to correlate with the clinical picture symptoms, labs, especially bilirubin and liver enzymes and other imaging, usually ultrasound.
Give me an example.
Okay, say you see hardly any tracer getting into the ducts, poor excretion. If the patient's bilirubin is normal or only slightly up, you're thinking high-grade obstruction is likely. But if their bilirubin is sky-high, it's probably severe hepatocellular failure. Same scan appearance, totally different interpretation based on the context.
The tracer just shows physiology. You connect the dots.
Exactly. You integrate everything.
Before we get into the how-to, quick safety check, contraindications, warnings.
Pretty straightforward, thankfully. The absolute no-go is known hypersensitivity to the actual HIDA compound, but that's really rare. There's a theoretical mention of allergic reactions if someone gets multiple doses over time, but again, uncommon. Pregnancy is the other big one, generally considered an absolute contraindication unless there are really compelling circumstances. And for that, you'd refer to the broader SNM guideline for general imaging for detailed risk assessment. #tag2, technical setup and pre-procedure precision. All right, let's get technical. Setup and prep. This is where, for you interpreting the scan, so much of the diagnostic accuracy is determined before the patient even gets the tracer.
Okay.
And the number one source of error, the thing that causes the most false positives, it's all about the patient's fasting status.
Right. Fasting. It seems simple, but you're saying it's the biggest trap. Explain that. Why is it so critical?
It boils down to how the gallbladder works. It stores bile. When you eat fat, your body releases CCK, cholecystokinin, which tells the gallbladder to squeeze and empty. So if the patient eats right before the scan, their gallbladder might be contracted, empty. When we inject the tracer, it can't get in easily or it fills really slowly. That looks like there's a problem, like a blocked cystic duct, even when there isn't.
Mimics pathology.
Yeah.
So what's the rule? How long should they fast?
For adults, the absolute minimum is 2 hours. But honestly, the guidelines strongly prefer 6 hours. That gives the gallbladder enough time to relax and fill up properly so we can clearly see if the tracer gets in.
And for kids, infants.
It's a bit shorter, 2 to 4 hours for children and just 2 hours for infants. And for infants, clear liquids are generally okay if needed.
Okay, 6 hours preferred for adults.
Yeah.
But you mentioned a trap with too much fasting. How does that cause a false positive?
Right, this is the other side of the coin and super important. If a patient has fasted for more than 24 hours, think critically ill patients, someone on TPN, maybe post-op NPO for a long time, their gallbladder hasn't been stimulated to contract at all. The bile inside becomes really thick, sludgy, almost static. So even if the cystic duct is wide open, the radioactive bile we inject just can't push its way into that sludgy gallbladder.
So it looks like it's blocked, but it's actually just full of sludge.
Exactly. Non-visualization leading to a false positive diagnosis of acute cholecystitis. It's a functional failure, not a mechanical blockage. The guidelines are very clear. Prolonged fasting is a known cause of false positives.
Wow, okay. So that post-op patient who's been NPO for a day and a half could easily get misdiagnosed.
Easily. That's why you need to know the fasting history.
So how do we avoid that trap if someone has been fasting too long?
You have to intervene before the scan. Pre-treatment with Syncalib, the CCK analog, is required in these cases.
So you give them CCK to make the gallbladder contract before the scan.
Precisely. You give the Syncalib, it stimulates the gallbladder to empty out that old viscous bile and sludge. Then you wait a bit, let it relax, then you start the HBS study. You're basically resetting the gallbladder so it's ready to fill with the tracer.
Okay, crucial step. Now, the tracers themselves, what are we using?
The main players are technetium 99-meter labeled IDA derivatives, specifically disophenin, which is disopropyl IDA, or mebrofinin, which is tribromo IDA. You might see it called collodium too.
Is there a preference?
Yes. The BNMS guideline actually states a preference for mebrofinin, and there's a good reason, especially in certain situations. Mebrofinin has higher hepatic extraction.
Meaning the liver grabs it more efficiently.
Exactly. Even if the liver function isn't great, or if there's high bilirubin competing for uptake, mebrofinin tends to get extracted and excreted better.
So if you suspect liver dysfunction or the bilirubin is high,
Mebrofinin is definitely the way to go. It's always preferred in jaundiced patients, and it's the standard for neonates being evaluated for biliary atresia. For exactly that reason, you need a tracer that can overcome that high bilirubin level.
got it. Let's talk dose. What are the standard amounts?
For adults, the SNM guideline gives a range of 111 to 185 megabecquerels, which is about 3 to 5 millicuries.
Okay.
But importantly, they note you might need to push towards the higher end of that range if you're dealing with high bilirubin or expect slow uptake due to liver issues. The BNMS sets their diagnostic reference level, or DRL, at 150 MBQ.
And for pediatric patients, it must be weight-based.
Absolutely. It's a $1.08 text MBQU, which translates to €8.5 text MTU, but there's a minimum dose threshold of $18 in 5 taria, about half a millicurie.
Even for tiny infants.
Yes, and actually for those really critical neonatal studies looking for biliary atresia where you need good counts, even with potential poor excretion over 24 hours, the SNM says use a minimum of $37 text RQ or 1 milliturie, and definitely use mebrofinin.
Okay, precision matters there. Let's move to the actual imaging camera setup. acquisition?
Standard stuff, mostly. You need a large field of view gamma camera. Collimator should be a low-energy all-purpose, EAP, or maybe a low-energy high-resolution if you need finer detail.
And how do we acquire the data?
This is key. It has to be a continuous dynamic acquisition. You're watching flow over time. Usually an anterior view, sometimes LAO left anterior oblique, can help separate the gallbladder from the duodenum. Standard matrix is $128 times $128. And you acquire frame by frame, typically one frame every minute for at least the first 60 minutes.
One frame per minute. That gives you the raw dynamic data.
Yeah.
But you mentioned image display and scaling being a potential pitfall.
Yes, this is subtle but critical for correct interpretation, especially if subtle findings or delayed filling. You'll reformat the raw data into, say, 4 or 6 minute summed images for easier review, and you absolutely need to watch it as a movie loop. The pitfall is the intensity scaling. It must be study relative. That means the brightest pixel in the entire 60-minute or longer acquisition sets the maximum brightness for all the frames.
Okay, why is that so important? What happens if it's frame relative?
If each frame is scaled independently, frame relative, the initial images with lots of activity in the liver and blood pool will look bright. But later, when you might have just faint activity starting to appear in the gallbladder or bowel, those frames will be scaled relative to their own low counts and might look artificially dark or completely black. You could totally miss subtle or delayed filling.
Ah, I see. So study relative scaling keeps the brightness consistent across the whole movie, letting you actually see the tracer move and accumulate over time, even if it's faint later on.
Precisely. It preserves the relative changes in activity concentration, which is fundamental to interpreting HBS dynamics. Get the scaling wrong, and you can easily misinterpret the study.
Okay, this is where HBS gets really dynamic, literally. We're not just passively watching. We often intervene pharmacologically. We're talking syncalate and morphine.
Absolutely. These interventions are often what elevates the study from just observational to truly diagnostic, especially for functional disorders or tricky acute cases.
Let's start with syncalate, the CCK analog. Its main job is for gallbladder ejection fraction, GBEF, right?
Exactly.
Yeah.
GBEF quantification is the cornerstone for diagnosing functional biliary pain, particularly that chronic acalculous gallbladder disease we mentioned. It tells you if the gallbladder muscle itself is working properly.
Now, I know historically there was a lot of variation in how GBEF was measured, especially regarding how fast the syncalate was given. That caused confusion, didn't it?
Huge confusion. If you look at older literature or even current practice that isn't following guidelines, you see wildly different normal GBEF values. The problem was often very rapid infusions, like over just 3 minutes.
What's wrong with a quick infusion?
It's not physiological. A rapid bolus or short infusion causes a massive sudden spasm of the gallbladder, not a smooth contraction. In healthy people, this spasm could actually trap bile or impede outflow, leading to an artifactually low GBEF.
So you'd get a false positive diagnosing gallbladder dysfunction when it was just an effect of the drug infusion method.
Precisely. Sending people for surgery they didn't need. The guidelines really aim to standardize this to eliminate that variability.
Okay, so what are the correct guideline-approved methods now?
There are 2 main validated techniques emphasized by the SNM. The one they prefer, mainly because studies showed it had the least variability among healthy volunteers, is a slow infusion. $0 into 2 decks. Infuse over a full 60 minutes.
60 minutes? That's quite long.
It is, but it's designed to mimic a more natural post-meal CCK release. For this specific 60-minute infusion method, the normal GBEF threshold is generally accepted as greater than or equal to 38%.
Okay, 38% for the 60-minute infusion. But you said 2 methods. I recall reading about another one with stronger sort of clinical validation.
Right, and this is important for evidence-based practice. While the 60-minute infusion showed low variability, the other method is actually the only one currently backed by a prospective randomized clinical trial, specifically looking at outcomes in patients with chronic acalculous gallbladder disease.
Ah, okay. And what's that protocol?
That one is $0, $16,000 DARPs, infused over 45 minutes. A bit faster, slightly different dose calculation. And for this 45-minute method, the suggested normal GBEF cutoff is a bit higher, usually greater than or equal to 40%.
So 45 minutes, 0.15 AKA, cut off 40%, versus 60 minutes, 0.02 AKA, cut off 38%. You need to know which protocol your institution uses.
Absolutely. And the key point for both validated methods is the slow infusion time, 45 or 60 minutes. That's the crucial element to avoid the spasm artifact from those old 3-minute techniques.
So, bottom line for GBEF, avoid rapid infusions like the plague. If you get a low GBEF result, your first question should be, how long is the infusion?
Exactly. If it was a short infusion, the result is questionable, potentially invalid. Strict adherence to the 45 or 60-minute protocol is paramount for accuracy.
Okay, let's switch gears to morphine. This is our go-to for nailing down acute cholecystitis when the gallbladder doesn't show up initially, right?
Correct. Morphine augmentation is a powerful tool in that specific scenario.
What's the protocol? When and how do you give it?
So the situation is, you've been imaging for about 30 to 60 minutes, you see good liver uptake, tracer is flowing into the common bile duct, and importantly, you see activity down in the small bowel, but no gallbladder visualization.
Okay, so bile is getting to the duodenum, but not into the gallbladder.
Exactly. At that point, you administer morphine sulfate. The dose is typically 0 and 4/10 Ds, or often just a standard adult dose of 2 milligrams is used. It's given IV slowly, over about 2 to 3 minutes.
Now, explain the mechanism again. Morphine constricts the sphincter of Oddi. How does closing the exit door help fill the gallbladder? It seems backwards.
It works by increasing pressure upstream. Think of it like plumbing. Morphine causes that sphincter of Oddi, the valve controlling bile flow into the duodenum, to spasm shut temporarily.
Oh.
This blockage at the exit causes bile pressure to build up throughout the common bile duct and the ducts within the liver. If the cystic duct, the little tube leading into the gallbladder, is open, patent, this increased pressure will force the radioactive bile backwards, or rather, sideways, into the gallbladder.
It follows the path of least resistance, which is now the gallbladder, because the main exit is clamped shut.
Precisely. But if the cystic duct is blocked, which is the underlying problem in acute cholecystitis, then even with that increased pressure, the tracer still can't get into the gallbladder.
So if the gallbladder still isn't seen 30 minutes after giving morphine,
that confirms functional obstruction of the cystic duct, and in the right clinical setting, confirms acute cholecystitis with very high confidence.
got it. But you mentioned prerequisites. You need to see tracer in the ducts and bowel before giving morphine.
Absolutely critical. First, you need to be sure there is radioactive bile in the common bile duct to be forced anywhere. Second, you need to see activity already in the small bowel. Why? Because if tracer isn't getting to the bowel even before morphine, it suggests there might already be a significant blockage lower down in the common bile duct itself.
And giving morphine then wouldn't help and might just dangerously increase pressure.
Exactly. Morphine augmentation is only useful if the path to the duodenum is initially open, but the gallbladder isn't filling.
Okay. One more intervention area, the specific pediatric stuff for suspected biliary atresia.
Right, back to those jaundiced neonates. Because their liver function might be immature or affected by the underlying condition, and bilirubin levels are high, we often need to help the liver excrete the tracer more effectively to get a clear answer.
How do you do that?
The standard approach is pre-treatment with phenobarbital. It's an enzyme inducer. The dose is $5 Texmeller per day, given orally in 2 divided doses for at least 3 to 5 days before the HBS scan.
5 days of phenobarbital for a baby.
Yeah.
That seems like a long time, and doesn't it cause sedation?
It does, and that's a drawback. It requires planning, and sedation can be an issue. That's why the guidelines also mention an alternative.
Which is?
Ursodeoxycholic acid, or URSO, given at $20 Texminjuegal per day for just 2 to 3 days before the scan.
Advantages.
Shorter premedication period, and crucially, no sedation. So it's often a preferred option if available and clinically appropriate. And remember, for both protocols, mebufotenin is the tracer of choice due to the high bilirubin, #5P, interpretation criteria, and differentiating pathologies.
Okay, we've prepped the patient perfectly, chosen the right tracer, done the dynamic imaging, maybe used Syncholide or morphine. Now, let's interpret. What does a completely normal HBS study look like?
Normal is smooth and timely flow. You see the liver light up almost immediately as it extracts the tracer from the blood. Then, quickly, activity clears from the blood pool, heart. Sequentially, you see activity appear in the intrahepatic ducts, then the common bile duct, then the gallbladder should visualize, and finally, activity spills into the small bowel.
And the key timing element.
All of that gallbladder visualization, A&D, small bowel visualization, should happen within 60 minutes of injecting the tracer. That confirms both the cystic duct and the common bile duct are patent and working fine.
Okay, so non-visualization is the big red flag, especially for acute cholecystitis. How is that defined precisely?
The scintigraphic definition for acute cholecystitis, whether it's caused by stones or not, a calculus, is persistent non-visualization of the gallbladder. The timing is critical here. It's defined as non-visualization after 3 to 4 hours of standard passive imaging.
Okay.
Or if you used morphine augmentation, non-visualization, 30 minutes after the morphine injection. If the patient has the right symptoms, pain, fever, that finding is highly specific for acute CC.
And you mentioned something earlier called the RIM sign. What is that again?
Ah, yes, the RIM sign. That's a specific and frankly ominous finding. It suggests severe, complicated acute cholecystitis, think phlegmonous or even gangrenous inflammation.
How does it look?
You see a curved band of increased tracer activity in the liver tissue right around the gallbladder fossa, while the gallbladder itself remains unseen. It's thought to be due to intense inflammation and increased blood flow in the liver adjacent to the really sick gallbladder.
So seeing that RIM sign implies a higher risk of complications like perforation.
Absolutely. It's a sign that things are advanced and usually prompts urgent surgical consultation.
Okay, that's acute. How does chronic cholecystitis look different? The symptoms can overlap sometimes.
The key difference in chronic cholecystitis is that the cystic duct isn't completely blocked, or maybe it's only intermittently blocked. So on HBS, you typically see delayed visualization of the gallbladder.
Meaning it doesn't show up in the first hour?
Right. Maybe it fills only on delayed images taken out to 3 or 4 hours. Or perhaps it only fills after you give morphine. Another suggestive pattern is seeing the gallbladder visualize after you already see tracer clearly in the small bowel. That implies bile is flowing down the CBD preferentially, suggesting some functional obstruction or issue with the cystic duct pathway.
Okay, so delayed filling points towards chronic, persistent non-visualization points towards acute. Let's shift downstream, common bile duct obstruction. How does that show up?
Well, the most common sign suggesting partial CBD obstruction is delayed biliary to bowel transit, meaning you don't see tracer reaching the small bowel by that 60-minute mark.
But you mentioned a caveat there earlier.
Huge caveat. Delayed transit by itself can be a normal variant in up to 20% of healthy people. So you absolutely cannot call obstruction based solely on transit time. Clinical context, labs, other imaging essential.
Can you tell high grade from partial CBD obstruction on the scan?
Often, yes. In a high-grade, basically complete CBD obstruction, the liver takes up the tracer fine, but then nothing gets out. You see the liver stay hot, maybe see dilated juncts within the liver fill, but no activity progresses down the CBD or reaches the bowel, even on very delayed images, like 24 hours.
Stuck in the liver.
Exactly. Whereas with partial CBD obstruction, tracer usually does fill the duct system, maybe down to the point of blockage, but it clears very slowly from the ducts proximal to the obstruction. You'll see persistent ductal activity at 60 minutes or on delayed views, long after the liver itself has cleared.
Okay, now what about that tricky condition, sphincter of Oddi dysfunction, SOD, especially after gallbladder removal?
Right, SOD. This can be a diagnostic headache. Scintigraphically, it often looks very similar to partial CBD obstruction. You might see dilated ducts, definitely see delayed bowel transit, because the problem is at the exit point, the sphincter.
So how does HBS help differentiate?
Well, the BNMS guideline mentions an interesting potential role for quantitative HBS here. They suggest it might help distinguish two subtypes. True sphincter of Oddi spasm, SOS, where the muscle itself is dysfunctional, versus something called cystic duct syndrome, CDS, where symptoms might relate more to the cystic duct remnant or scarring after surgery.
How would they look different functionally?
Theoretically, in cure SOS, the gallbladder, if still present, or the system's response to CCK might be normal, so GBEF could be normal. In CDS, you might expect an abnormal response or low GBEF if the issue is functionally related to the gallbladder cystic duct region. It's complex and often needs correlation with manometry, but HBS can provide functional clues.
Do interventions help diagnose SOD?
The guidelines suggest that using Syncalid or sometimes even morphine might provoke or exaggerate the abnormal sphincter function, potentially increasing the sensitivity of HBS for detecting SOD by highlighting the delayed emptying or increased pressures.
Okay, lastly, quick review of bile leaks and reflux.
Bile leak is pretty straightforward conceptually. You see tracer pooling or tracking somewhere. It shouldn't be outside the liver, ducts, gallbladder, bowel, or urinary tract, which can have faint activity from renal excretion.
Finding it can be tough, though.
Sometimes, yeah, especially small leaks. Using the SIN display is crucial. Maybe changing patient position, like decubitus views, can help spilled bile layer out or move, separating it from overlying bowel loops.
And bile reflux.
That's seeing tracer go backwards from the duodenum up into the stomach. If it's just a tiny bit, maybe not significant. But if you see marked reflux and the patient has symptoms like persistent upper abdominal burning or nausea, it correlates pretty well with biogastritis. Hashtag #TAG-V, sources of error and safety parameters.
Okay, sticking with our focus on technical excellence for you, the radiologist listening, let's hammer home the sources of error. Knowing why a study might be wrong is just as vital as knowing the normal patterns.
Couldn't agree more. Quality assurance starts with understanding the pitfalls. Let's break down the false positives first. Situations where the gallbladder doesn't visualize, but the patient doesn't actually have acute cholecystitis.
We covered the big one already.
Right. Fasting issues. Either too short, less than 2 hours, gallbladder contracted, or, more commonly misinterpreted, too long, over 24 hours, TPN, severe illness leading to sludge. That prolonged fasting is a huge trap.
What else causes false positive non-visualization?
Severe liver disease. If the hepatocytes are too sick to even extract the tracer properly, not enough gets to the bile ducts to visualize anything. Also, a high-grade common bile duct obstruction. If bile can't get down the CDD, it obviously can't backfill into the cystic duct.
Okay.
Other causes. Patient already had their gallbladder removed. Previous cholecystectomy, always check surgical history. Or, occasionally, super rapid biliary to bowel transit. Everything flushes through so fast there's just not enough tracer left in the system to fill the gallbladder, even on delayed views.
Let me just pause on the prolonged fasting versus the high-grade CBD block. Both cause non-visualization. How do you differentiate those two when you see the scan?
Great question. You need the context. Prolonged fasting patient, often critically ill, maybe on TPN. Bilirubin might be normal or only slightly off. Liver uptake itself might look okay initially. High-grade CBD obstruction usually presents with rapidly rising bilirubin, maybe RUQ pain. Liver uptake might look okay, but you see no excretion into guts or bowel over time. The clinical picture and the LFTs are key.
Got it. Now, flip side, the false negatives. These seem potentially more dangerous. The gallbladder visualizes, making you think things are okay, but the patient does have acute cholecystitis. How does that happen?
Less common, but crucial to know. A classic technical error is mistaking a loop of bowel, maybe the duodenum, overlying the gallbladder fossa for the actual gallbladder.
How do you avoid that?
Watch the Singlu carefully. Bowel peristalsis looks different. If unsure, get a right lateral view. It separates the anterior gallbladder from the more posterior duodenum.
Okay, what else?
Acute calculus cholecystitis can sometimes be tricky. The inflammation is real, but maybe the cystic duct isn't completely permanently blocked early on, allowing some tracer to sneak in. Also, there's the rare dilated cystic duct sign.
What's that?
The cystic duct itself is inflamed and dilated, and it pulls enough tracer to look like a small, faint gallbladder. The guideline specifically warns not to give morphine if you suspect this sign, because you could theoretically increase pressure in a very fragile, inflamed duct.
Right. Dangerous. Any other false negatives?
Gallbladder perforation. If the gallbladder has already ruptured, the leaking bile containing the tracer might pool right next to the gallbladder fossa, and you might mistake that pericholecystic fluid collection for activity within the gallbladder itself. Again, cystian and maybe lateral views can help.
Okay, good list of traps. Finally, we have to touch on radiation safety. Standard part of any guideline. What are the key dose figures?
The guidelines provide detailed info, but for a quick reference, the BNMS states the effective dose for a standard adult dose of mebrofenin is around 2 millisieverts MSV. That's relatively low, comparable to some CT protocols.
And which organ gets the highest dose?
Consistently, regardless of the specific IDA tracer used, it's the gallbladder wall. Because the tracer is concentrated and stored there, the SNM tables give specific values, like around $0.1110 milligray per megabecquerel mg/MBq absorbed dose to the adult gallbladder wall.
Okay. And the common questions about pregnancy and breastfeeding.
For pregnancy, as we said, it's usually contraindicated, but if essential, fetal dose estimates are available in the guidelines to help with risk counseling based on gestational age. For breastfeeding, there's really important and reassuring news from the ICRP cited in the guidelines.
What is it?
For these technetium 99-meter IDA compounds like disophinin and mebrofenin, the recommendation is that lactating patients require no interruption of breastfeeding.
No interruption at all.
None needed. The amount excreted in breast milk combined with the short half-life means the dose to the infant is considered negligible. That's a huge relief for counseling new mothers who might need this scan. #TagOtro. So, if we pull all these threads together, what's the big picture for you, the practitioner, interpreting these studies?
I think the overwhelming theme from these guidelines is the move towards quantitative measures and absolutely rigorous standardized technique.
Yeah, it's not just about does it fill or not anymore.
Not at all. It's about the GBEF percentage derived from a specific slow infusion protocol. It's about hitting those precise time points for delayed imaging or morphine administration. It's about managing fasting correctly. This technical rigor isn't just academic, it's essential for getting reproducible, reliable data, especially for diagnosing those functional biliary disorders.
And that rigor in technique leads right back to the fundamental principle of interpretation you stressed earlier. Exactly. No matter how good the scan looks, no matter what the GBEF number is, the guidelines are crystal clear. HBS results must always be interpreted within the full clinical context. Labs, symptoms, other imaging like ultrasound, you have to put it all
The
together.
scan provides the physiological data.
You provide the integrated diagnosis, making sure, for instance, that you don't mistake functional non-filling due to prolonged fasting for true mechanical obstruction from acute cholecystitis. That integration is the core of expert practice.
Well said. Okay, before we wrap up, we always like to leave our listeners with a final thought, something to chew on.
Okay, here's one building on what we just discussed about dose. We know the highest absorbed dose goes right to the gallbladder wall, and we know mebufotenin works well even with poor liver function. So, thinking ahead,
Yeah.
how might we leverage that? Especially with hybrid imaging like SPECT-CCT, which we mentioned for pre-op liver assessment. Could we use that precise anatomical localization from CT combined with the functional uptake data from SPECT, not just for diagnosis, but perhaps to get really accurate patient-specific dosimetry? Could this eventually help optimize tracer choice or injected activity, maybe even plan therapies, especially in sensitive cases like those infants being checked for biliary atresia where minimizing dose is paramount?
Hmm. Using the functional targeting for more precise dosimetry and planning. That's a fascinating direction. Definitely something to think about.
Food for thought.
Indeed. Well, that is all the time we have for this deep dive into the HBS gold standard. We really hope drilling down into these technical and clinical details has been valuable for your practice.
Thanks for tuning in. Keep thinking critically and safe scanning out there.